Welcome. Okay, I think we'll get started. So hi, everybody. Nice to see everybody. I think most of you know me, but I'm Nancy Byatt, Director with Tiffany of this network of access programs. And what we're going to focus on today is engagement. This is a topic that, as we were talking about sort of what topic we were going to do today, we thought, well, we've done engagement, but we feel like this is sort of a topic we can never talk about enough because it's just so challenging. So we're talking about engagement and Perinatal Psychiatry Access Programs today. And can you go to the next slide, please, Melissa? And so for housekeeping, just a reminder of some of the housekeeping. So please keep yourself muted. But when you're talking, please turn your camera on and please unmute yourself. If you have background noise, particularly mute yourself. We are recording this meeting. If you have any questions, email D or any technical problems. Next slide, please. And a couple reminders about some of the network activities is that, we're continuing our monthly meetings, always on the second Tuesday of the month. The topic on October 12th is going to be interfacing with women's mental health programs. What we're going to talk about is a lot of times challenges come up with people. A lot of you have, and a lot of our programs have a women's mental health clinic or practice, and they have their own access program. So how do you interface between that? And how do you sort of not have your program become a backdoor to that? Or how do you, also they're not closed doors, but also still build capacity to have them manage less complicated patients? And it's actually, as I'm sure you all know, very complicated to sort that all out. So, yep, I see Karen saying so relevant. So so that's what we'll be talking about, and really having a couple of programs present on that and their experiences, and then also, and then having a discussion. And if anyone's interested in being on a panel for that, we welcome, anyone, because this is stuff we've all experienced and it's very challenging. So we welcome, if any of you are interested in that, either enter into the chat or let Melissa know. We welcome some additional panel members for our discussion. Now, November 9th, we'll do our program exchange. Our topic is to be determined. And then next slide, please. And we do have the date for our annual summit. It's going to be, we're now, as you may be aware, we used to do these biannually, and then now we're doing them annually. It will be virtual again. And it's going to be March 2nd and 3rd, both days, from 12 to 4:30 p.m. Eastern Standard Time. And, we'll be in touch more about the topics. And we decided to move it into the spring, largely because there's so many conferences in the fall that we thought we'd move it into the spring where there tends to be less conferences, because I think a lot of us have many other conferences in the fall. That's why we moved it to the spring, so it doesn't conflict with all the other conferences. And next slide, please. So coming back to the topic for today, so just give an outline of what we're going to do. So I'm sure most of you probably know Christina Wichman from Wisconsin. So Christina's going to give a presentation on what her program, the Periscope Project, has been doing in Wisconsin, and give an overview. They've had I think, they have a lot of utilization, had a very successful engagement approach. And then I'll give an overview of what we've done in Massachusetts. And then after that, we're going to have a discussion. And what we'll be focusing on also is how is this different now? Because right before this, we were talking, and Melissa reminded me that the last time we had a deep engagement webinar was actually, it was like in beginning of March, like right before COVID. I remember during that, some person had to get off and put, I got to go, the state's declaring a state of emergency. And so engagement's changed a lot since then. And as I alluded to, this is just always an iterative process where we're all learning, because it's really challenging. And just to be very clear about it, it's a lot harder now. And so we'll talk about that, and we'll talk about how we need to adapt some of these for, these times, which is not a lot of in-person, what we use, a lot of in-person stuff we used to do, it just isn't possible anymore. So, and now I'm going to introduce Christina. So as you mentioned, a lot of you know her. She's the medical director of the Periscope Project and a perinatal psychiatrist. She's at the Medical College of Wisconsin. I've known Christina for, I don't know, I feel like since it's like
we were babies.
a long time, since both of our access programs were in utero. And it's, Christina, as I mentioned, has an access program, and they've been successful. So welcome, Christina, and thanks for presenting.
Thanks so much for having me, Nancy, and to all of Lifeline for having me. Let me see if this is working. So far, so good. All right, awesome. Okay. Yeah. All righty, so Lifeline has asked me to talk a little bit about what Periscope has done. And as Nancy shared, a lot of this has changed in the last 18 months or so. So I'm going to highlight a little bit of a kind of pre-COVID, and nobody likes the term post-COVID. We are not post-COVID. We are in the midst of COVID. And so what we're doing differently now, because again, so much of that in-person engagement obviously has really changed. So broad overview, kind of tactics that have worked for us here in Wisconsin. We have learned time and time again that no matter how much we put our staff in front of people, that has never led to utilization. So Shelby is phenomenal. Y'all have met Shelby. She's fantastic. I can put her in front of a group. She can talk about this program inside and outside, upside down. They will not utilize our program if Shelby goes and talks about it. They need to vet the psychiatrist who will typically be answering the phones. Now, we're a really small program, so for 4 years now, that's primarily been me. We have just started branching out in the last year of having coverage other than me here pretty consistently. But they need to vet the expertise of a perinatal psychiatrist. So we have found that it wasn't enough to have our staff, our coordinators, or triage, whoever those non-clinical folks may be, that's never been enough. It really has had to be, in our experience, the psychiatrist who's going to be answering those phone calls, who's doing the engagement piece, so that they can vet that expertise of that person. And how to vet them, to be able to showcase and demonstrate their knowledge has been really helpful, and to show them how they teach. So it's not just about having this great knowledge base, it's about being able to demonstrate how you could teach it to that calling provider. And so we've targeted lots of different places to be able to do this. Didactics within residency programs has been a huge success for us, because that's something that we then have an ongoing relationship with. Maybe not every year that we're circling back, but at least every other year. So we've targeted all of our OBGYN residencies across our state, all of our family medicine residencies. We're a very rural state, so we have pretty substantial number of family medicine residencies. We have 4 psychiatry residencies in our state. So we've done didactics at all of those programs, and then now are set up with their residency coordinators on a biannual basis to come back and do updated didactics. So then we're getting at those psychiatrists, OBGYNs, family practice docs early in their careers. And so they've made Periscope and these kinds of access programs part of their careers from the very get-go. Other medical hubs that we've targeted have been our federally qualified health centers here in the Milwaukee area. Primarily, that's where we've had a lot of with to do didactics, particularly during their staff meetings, and I'll talk about that. Other places that we've gone have been our statewide conferences. So the Wisconsin chapter of ACOG, Wisconsin Association for Perinatal Care, lactation conferences, our Midwives Association group that originates in Wisconsin, as well as Wisconsin Psychiatric Association. You'll hear psychiatry coming up. About 20% of our utilization now is with other psychiatrists here in Wisconsin. And so we've, while we never meant to initially target psychiatry or mental health providers, that organically has grown over the years. And so we've done a little bit more targeting recently with those groups as well. Again, didactics, formal education opportunities, sessions, oftentimes they are reaching out to us to do a topic. On the flip side, we oftentimes will reach out to these conferences and say, can we just have 5 minutes during a session like that? So pre-COVID, when they were doing not a breakout session, but kind of the entire room together. Can we have 5 minutes of that time just to introduce our program and then direct people to a vendor table in those instances? Not a whole lot of traffic at those vendor tables, but at least, again, a little bit of chatter at those statewide conferences. The other thing that we learned very early on is that it never worked to schedule a meeting that was outside of their regular scheduled meeting times. So I'm talking about a clinic or a hospital setting. Go to them during times that they're already meeting, whether it's their grand rounds, their scheduled staff meetings, work around their schedule. The few times that we tried to have meetings that were on my schedule and that they would try to get folks in. Never worked. Nope. You just need the flexibility to go on their schedule. That's the third Tuesday at 2 p.m. Well, that's when you go, or you make somebody available to do that, because you're going to have more people that are showing up to those sessions that they're already planning to attend on a regular basis. We need this top-down and bottom-up approach, which we'll talk a little bit more with the different slide. We really need to utilize our other connections. So here in Wisconsin, we have a really robust peer-to-peer support community. And so we've partnered with them for us to refer to them as part of our community network, but also for them to have the patients that reach out to them advocate for their providers to use Periscope. And so actually having patients say, I think I need a medication. I know you're worried that I'm breastfeeding and I'm pregnant. There's this program called the Periscope Project. And so having some of that approach actually come from the patient and moms themselves. All right. We have found it really important over the last 4 years to figure out kind of what our targeting messaging is. And ours has always been about ease of use and how we make that frontline provider's job easier. And that's how that's been a lot of our big frame over the last 4 years. How we are a benefit to the clinic, we're a benefit to the patient, making it clear that there's no cost associated with the program for both the patients and the providers, and that we're not looking to quote unquote steal patients. I think next month when we talk about interfacing with women's mental health programs, that's important because there's that dual role that I have with my own clinic through the medical college. But it's really clear that when I'm putting on my Periscope hat, I am not just trying to shovel patients over to that clinic that I also have. So we had a lot of difficulties with some of our competitors early on that they thought this was a program just to get patients funneled over to Frederick in the medical college, and that clearly wasn't the case. So I had enough patients without trying to get more from Periscope. So. And try to put yourself in their shoes. Like, what would make you hesitate to utilize this program, and try to address that in your correspondence? Is it the timeliness? Is it how is it going to fit into my day? Is it that you're not worried about who you're calling or who you're talking to? So really try to ask yourself those kinds of questions, particularly if they are specific to your state or region or program, and address that initially in your correspondence. We started 4 years ago with what we always termed our low-hanging fruit. So who was that? Well, I work for the medical college. So we started with the medical college. Who are my personal contacts within the OBGYN community, within the psychiatry community? And we worked out from Frederick and the medical college proper, so the hospital system, and then went out to the clinic system. Beyond that, we started going to these statewide contacts, residency programs, and kind of built up from there. Right now, we're at these upper branches. We've got a couple of slides about clinics that have a high number of births, but they haven't engaged yet. Cold calls and emails really have been very difficult to engage with clinics where we don't have that warm handoff. So don't start there. Or clinics that keep saying no. Like, you have to continue to engage as much as you can, but start with your low hanging fruit and build from there. Because what we have found over and over and over again, particularly in the last 12 to 24 months, is that our new utilizers are those who are hearing about us through word of mouth. We've really had no marketing dollars spent in the last 1 to 2 years, just kind of where we're at with funding, yet we're continuing to have increased utilization from new and unique providers. And the question that we ask them when they are a new user to our program is, how did you hear about us? And inevitably, it's from a colleague. So if you start with the low-hanging fruit of who you have personal contacts with, who is within your system, and build from there, organically it will grow, or it certainly has for us at least. Early on, we really needed this top-down and bottom-up approach, and we did it simultaneously. So we needed the systems, we needed the leadership from our healthcare systems, So we did emails, one-on-one meetings with our healthcare leaders. We attended large meetings to talk about that, to have the buy-in from that healthcare system or that clinic, their management, as well as from the provider level. So we needed those who would be utilizing our service to know about us, but we also needed to be able to tell those providers, we have been in contact with your leadership. They are involved and engaged, and they support your use of this program. Because if we were just targeting the providers, inevitably there was questions and concerns about whether their leadership supported them using a program that was, especially if it was outside of their system. And if we only targeted leadership, inevitably the message wasn't getting down to the providers, and the providers again didn't have the opportunity to vet the psychiatrists. So we did this top-down and bottom-up approach simultaneously for that first 1 to 2 years that we were out there. And again, that was pre-COVID, so we were in front of people as much as we could in their settings. Multiple different approaches is going to build notoriety. And so the more contacts that they hear about us and different ways that they're hearing about your access program, the better. So maybe they hear about this program at a conference presentation, and they saw a post on social media, something was shared from a peer-to-peer support group. Maybe they then heard about it through a local news story, through the media. Then a colleague mentioned it, and then maybe you got an email directly from us. And now you've got a patient who's struggling, so that then they're going to reach out and call, or at any point along the way. So these are all different ways that we have reached out and tried to engage providers, as well as just here more recently, again in the last 12 to 18 months, patients themselves to get a little bit of chatter to talk to their providers about using us too. So we don't have a lot where that approach has resulted in a phone call, but it certainly has happened where the patient themselves has said, I've heard about this program, please call and see if they can be helpful to you to help me. Never say no because a group is too small. So I remember this group. Or yeah, I gave Shelby hell because of this group. So it was a 2-hour drive for me to do a didactic to an OB clinic. There were 4 people there. And I got on the phone with Shelby on the drive back. I'm like, what are we doing? We cannot continue to do this. This is not a great place or a good use of our time. Now, post-COVID world, I would have said, absolutely, give me a group of 4. It's a webinar. I don't have drive time, et cetera, et cetera. But during one attendee during that live session, so 1 out of those 4, 3 years later, that one provider has utilized us more than 20 times, plus has engaged another quote unquote super utilizer from that same clinic. And now we've had 10 total unique utilizers from that clinic. So even though only 4 people were at that didactic session, again, the word of mouth spread, and now we've got really great engagement from that clinic setting. So it was a lesson learned, even though I was pissy to poor Shelby about it when I did it at the time. So we also need to give them choices to fit their needs. So lots of different ways that we can engage with a group depending on where they're, what kind of session they're looking for, how much time they'll give us. I will never at this point say no, 5 minutes isn't long enough, because I know I can do a really brief 5-minute introduction of our program. And sometimes that's enough just to pique their interest and have me come back and do more. So can I do a didactic plus a brief informational session? Can I just do information alone about the program? Can I just do a didactic for your residency program and just leave information available later? Lots of different ways to do that. And you tailor it to what their needs are and what their timetable is. And again, always asking to come to an existing meeting time. It always makes me nervous when somebody says, oh, we'll set up a meeting at this time, blah, blah, blah. Nope. When do you already have your staff meeting? Even if I can't have as much time during a designated staff meeting time, I'd much rather have that meeting time than a separate didactic or a separate session setup. I said it earlier, I'll say it again. Shelby put a whole slide up on it. Vetting psychiatry really has been the key to utilization, at least for us. Time and time again, it's because they've heard me talk, or they've heard one of my other perinatal psychiatrists speak at a conference, a didactic, a lecture. They've heard us engage with providers. Once they vet us, then they're going to utilize us. Time and time again, our providers are telling us that they use us because they trust us at this point, and they trust the information that they're getting through our service. And so that vetting process is really key. And education does bolster action. So this is a great example. So West Dallas is less than 5 minutes from our office. It's literally down the street. But because it's a competing system to Freighter and the medical college, we had a heck of a time getting into that system. And they had a huge proportion of women and the number of births in Milwaukee County. So you can see that for those first 3 years, we only had 9 encounters with 5 unique providers. So really quite small considering the number of births that they had. So right prior to COVID, I'm very thankful I got this didactic in person on end of February 2020. Since that time, we've had 54 encounters with 24 unique providers. And this lovely provider says, I'm so sorry, but so many of my patients are having psychiatric problems, and it's hard to get them in. But it took that didactic, and took me, spending an evening. It was an after hours dinner presentation that we did that got them to vet me and then utilize. It was within 10 days, we had our first utilization based on that didactic, and it just snowballed from there. I do think it's super important for your utilizers to know what to expect. This is I don't know what we call it, a little schematic that we put up for all of our information sessions about exactly what to expect. So, and very clear guidelines as to how long what will typically take. So triage process, less than 5 minutes, less than 2 if you're already pre-enrolled. The consultation, the provider is going to call you back in less than 30 minutes, but our average return time is 6 minutes with a mode of 2 minutes. 8 to 10 minute conversation. Patient then, or the provider then discusses with the patient. So we go through what to expect during that informational session, and utilize that informational session to really highlight your strong points. Ours have really been our response times, and it's impressive to see that we've been able to do that without having a full-time psychiatrist tagged to this program. And our docs are super impressed by that, but also thankful for that, because they know if they've got a patient in the office or on a virtual call, that they can typically have a pretty quick turnaround. We utilize a lot of provider testimonials as well. And again, we frame it as a benefit to them. It's going to save you time in the long run if this patient's getting better and they're not struggling with depression, anxiety. They're not going to keep calling your clinic, and it's going to improve your patient outcomes. Don't give up on clinics that aren't utilizing but have high births. So again, another example, we had a clinic with a high number of annual births in Wisconsin. Over and over and over again, we got turned down by lots of different ways. Like the VP of OB introduced us. We had a peer-to-peer support introduction. We did a cold call. We did a warm handoff from a midwife. But what ended up happening was that a nurse heard a presentation at a statewide nurse conference. A nurse at that clinic then reached out to us because of that. So again, that notoriety is helpful, but also not giving up and trying different ways of connecting with clinics is super important as well. That's what I've got. I'm happy. Well, I will pause and let Nancy say whether or not I take questions now versus later. I'm happy to do so. Otherwise, if you prefer to do later, I'd be happy to do that too, Nancy.
Yeah, why don't we spend a couple minutes doing that now if people have questions? And I just want to, I'm on camera. I agree with everything you said. Like I think that was all great advice. And I think a couple things you said, I'll just highlight, is you mentioned that that people want to hear from the psychiatrist. That has absolutely been our experience too. We find that, and I think the other thing you said about how important word of mouth is. I think all of those things are just really important, but I just think everything you said, that was all great insights. But yeah, I think we could spend a couple of minutes. Did anyone have questions for Christina right now?
There's a few
Maria,
things in the chat.
Yep. I see. We got a few in the chat. Thank you. So we got, thanks so much. Oh no, that was in the way beginning. Thanks, Maria. Glad it's helpful. So Karen Burns asked, perhaps not endoscopic, but how much do you offer quick response times without full-time coverage from psychiatry? Interested to hear more about your staffing model.
Do you want me to cover that, Nancy? Or
Yeah, go ahead. Yeah, go ahead.
Yeah, so the way that we've done it, we've got 50% psychiatry time, and we've got the flexibility of that psychiatrist to build the rest of their day around that. So for instance, when I am seeing patients, I see a patient for 30 minutes, I've got a 15 to 30 minute break, then I see another patient. So I'm not seeing back-to-back patients, or if I've got administrative time or meetings, I'll not do them back-to-back. If I happen to be the ones staffing, I will build in breaks throughout the day, recognizing that even with as much utilization as we're having, typically if you're having, anywhere from 3 to 5 calls a day, you don't necessarily need a full-time psychiatrist, particularly if they're not doing a lot of these didactic presentations or going out and doing that engagement piece. So if it's just looking at line coverage, that's how we've made that work. Maria asked, I hear you right, respond within 6 minutes. So that is our average response time is 6 minutes. We respond within 30. So we tell people we will respond within 30 minutes, but our average response time is 6. Most commonly it's 2. So it's just enough time for me to pull up a computer and to review the notes and give a call back. Most successful way to get engagement during COVID. So didactics. So the things that we've continued to do that we've then toggled to, a lot of what we've talked about is still continuing, but it's continuing in a virtual format. So we've continued to engage with our didactics with our residency programs. We're continuing to engage with our statewide conferences just in a virtual format. The one thing that I didn't mention is we started offering a monthly webinar series, a webinar series post-COVID or during COVID that we will continue as a way to have that educational piece that is offered free to all of our enrolled providers then. And this year we had funding to be able to tag CME along with it. So any of our enrolled providers could log on and have an hour of free CME once a month to do that. And so that was a way to have some of that educational piece then as well.
Thanks, Christina. That's all helpful. I see we got one more question. Then I'll give my, talk a little bit about MCPAP for moms. Alana is asking, what has been your most successful way to get engagement during COVID? We'd love to go to conferences, but they want us to pay.
Yeah. So we've just asked flat out if we don't have to.
We've done the same thing. That's exactly what we've done. We're like, we're a public health program. Like, we don't want to pay. Because tables are like $5,000. And we're like, we're not a drug company. We're not selling a device. And then every time they've waived the fee.
Yeah.
They've been like embarrassed when we ask. And then they're like, of course, we're a free service, We've done the same thing.
You guys have the same thing. Yeah, we're funded by the state. That's exactly what we say. And so I haven't had a lot of pushback with that piece. It's been pretty rare, in fact, that we've had to pay for vendor tables or engagement in that regard.
I would agree. A couple other questions. Do you ever have issues when you can't meet that 30 minutes? Perhaps someone is on vacation, leave, or just busy with other consults?
Yeah, I can still count on one hand the number of times I've not made 30 minutes in the last 4 years. So no, we've been pretty lucky. And then with vacation, if I'm away, our covering the covering psychiatrists that we have, they know that well and enough in advance to redo their schedule to be able to accommodate that 30-minute mark as well.
Mm-hmm. Yeah. And then another question here. Was somebody going to say something? Did I hear someone say something? No. Okay. Is psychiatry time paid for by the state, budget line, others, or other payers, health insurance, et cetera? Such an excited program. Exciting. I think that's meant to be exciting, but you are both. You're excited about it being exciting.
Our program currently is funded year by year, which is a total pain in the butt, through Department of Health Services, the Title V maternal child block grant. So we have to apply for that and get that awarded to us year by year. And that also has a 75% match that comes along with it. So that's kind of where our initial funding was through United Health Foundation. So that really got us started for our pilot and got us through 2.5 years of operation. So we are just over 4 years now and working with the state. So our goal is to have a line item like other programs do, or to have some kind of more comprehensive program to be paired with perhaps our child psychiatry access program. But for right now, it's year by year with the maternal child block grant.
Cool. Great. Well, those are all great questions. So, okay. I don't know if we have any more right now. So I'll just give a little overview of some of the stuff we've done at MCPAP for moms. And then thank you, Christina. That was super helpful and really just practical. And it was great. So with MCPAP for moms, so I'll kind of just give a high level overview of some of the stuff that we've done and kind of building a lot of what Christina was saying. If you go to the next slide, please. So, as you heard about from Christina, we used a proactive approach with purposeful engagement and tracking. So one of the things that I agree with what Christina was saying, to build on what she was saying, that psychiatry time really matters. They want to talk to psychiatrists because also that builds a relationship, because if someone goes and they give a presentation and they're like, oh, this person's, we like them. They're smart. They sound like they know what they're talking about. They might want to talk to them again. So that really matters. And so one of the things that we found important is that the psychiatrists that are doing this have dedicated time to commit to this. That's like one piece that I'll come back to. The other piece we found is to track this. So you're tracking it and you have a systematic approach to doing it, which I'll also come back to. Direct outreach, as we talked about, face-to-face is great if you can do it. You can also do this remotely, which we can have a discussion about. Also going to where their providers are and meeting them where they're at. You heard about that from Christina as well. And then also conferences. So we just talked about presentations. Tabling is not really happening these days because of conferences, but both of those we found really useful. Next slide, please. So what we did, and when I talk about the tracking, I'm just going to get a little more concrete about that. It's very important to create an inventory and know what your denominator is. So for example, with what you may say, what do you mean your denominator? So for example, in Massachusetts, we have about 200 obstetric practices in our state. So we basically went through and we looked through these various resources to figure out what is our denominator. So then we know what is our target. So for example, in Massachusetts, we determined there was about 200 obstetric practices. And then we went through and we created a list and we had, okay, this is the practice, this is who we can contact, this is what's happened. And then we tracked all of that. That way, you know what your denominator is. And then, so for example, when you've recruited, 20 practices, you've recruited 10% of your denominator, you've enrolled 10% of the practices, and then you kind of keep going up. And that is a very important thing to do. And you might wonder, well, how do you get your denominator? It's actually way harder than I would like it to be. Ideally, you'd be able to kind of look up and there's some beautiful list of all the OB practices in the state, but there isn't in my experience. But, state agencies have some of this. You can look at the birthing hospitals and who's affiliated. We literally, Yellow Pages were, but virtual Yellow Pages like Google, and also the Board of Registration in Medicine has some of this information as well. Next slide, please. And so this next slide gives an example of like what our, for example, practice inventory look like in Massachusetts. This is an Excel file. And you can see that we would have, the hospital, the birthing hospital, the location, and then we'd have all the practices affiliated with that birthing hospital. And then we'd have the city and the contact information. And then we'd have, how many births they cover. So that way we know, okay, we're going to for example, ideally in the beginning, we're going to those lower hanging fruits. And also ideally you want to be getting those practices with the most births, because it's just, you're going to get more, you're gonna be able to cover more births that way. And then we'd record, have we done a training? So for example, here we did a November 2006. And if they were enrolled, we'd put whether they were enrolled or not, and et cetera. And our goal was that we would do, this is for the grand rounds. We try to do grand rounds in the birthing hospital. That's what's in the gray. And then underneath that would be whether we've done a practice level training. And then we assigned someone. For Christina, it was her. She was like a one woman show, kind of going all over the state driving. We in Massachusetts at the time had 5 psychiatrists, which is, our team has changed over time, and people had a region assigned. So what we would do is people would have a region and they would know that, okay, I'm responsible all for the practices in these regions. And then we would pick those regions based on Lena Mattal, for example, who a lot of you know, now our associate medical director, she's in Boston. So she had some of these practices that were in Boston because she could build on those relationships and go for the lower hanging fruit there. In Western Massachusetts, at the time we had Carolyn Brody. So she took the practices out there. And then we recorded, what happened, was their response and so forth. And so really keeping people accountable. And so this is sort of our inventory and how we used it. Next slide, please. And the goal was that we did ground rounds at all the birthing hospitals throughout the country. So I mentioned, we had this systematic way to document the practice level activity, what we were doing, if we called, was there a response? And then for every practice, we documented all of these things and we kept track of it. That all became data over the denominator. So for example, you've recruited how many practices, you called how many practices, you've trained how many practices, how many have you enrolled, and so forth. And these are all reportable because if you're all looking, I know a lot of you have, you are accountable for utilization and your encounters, and all of those things can count as your encounters that then you can report back to whoever it is you may need to be reporting to. Next slide, please. And so our team, what we had was at the time, we had a program, Kate Biebel, who was our program director. Now it's Beth McGinn, who does both the child and the maternal access programs. I was the medical director at the time and still am. Tiffany was our OB champion. And then we had a program coordinator. And then we had, as I mentioned, 5 psychiatrists. And then we had 3 resource and referral specialists. And really the bulk of the engagement sat with the psychiatrists. And we, as I mentioned, what we had was we actually had a map of the state. And then what we did was we split the regions up and each psychiatrist was assigned a region and practices. And then what we did was we would have meetings and we would literally run through that file, that Excel file I mentioned, and we'd go through and we would go through and we'd say, okay, all the practice, say, for example, that Carolyn Brody was responsible for, and we'd go through and we would talk about what happened, did you outreach, and things like that. And the expectation was, if the psychiatrist, in the beginning, it wasn't that busy. We were only getting a few calls a month. Now we're clinically busy, but at the time we weren't. And the expectation was that during their shifts, the psychiatrists still had protected time and they were calling practices, they were doing trainings, and they were doing direct outreach. And so that was sort of what we did. We really kept the psychiatrists accountable, and then we would create that accountability by reviewing it, because no one wanted to come to a meeting and be like, oh, I haven't called any practices. So in the meetings, we'd say what happened, and then we'd say, oh, I know that person, and we'd kind of help each other with that. And then, the coordination of it, once we made contact with the practice, our program coordinator would often help schedule it and so forth. That initial contact and the actual training happened with the psychiatrist. And the OB champion was critical too, because Tiffany, for example, made tons of connections because there's that word of mouth and building on those personal relationships. And with, for example, us doing presentations at ACOG and so forth. Next slide, please. So I mentioned a lot of this, that the accountability was critical. We dedicated time, the expectations were clear, we assigned the practices, and we monitored the progress, and we followed up on it. Next slide. And also, you heard about this from Christina. They wanted to have a clear, they wanted to know what was the enrollment process. One of the things that we found that practices often thought was, well, I don't, we don't want to commit to anything, we don't, it's too much, they're busy, they're beleaguered, especially during COVID. This is particularly important. And one of the things that we always did was we made it very clear, you are not agreeing to do anything. You are not committing to anything. You're agreeing to do some things, but you're not committing to anything. All an enrolled practice means is that you understand what we do and that you'll call us if you need us, and if you want to. That was really it. And, people often ask us, well, what if they were enrolled, can they engage in the program? Absolutely. Because if a program isn't enrolled, we use the term enrollment. We know other practices use the term often, registered or what have you. But for us, we use the term enrolled. All that meant is that they've been to a training and that they understand what we do. And that's really all it meant. Didn't commit them to doing anything. But if a practice wasn't enrolled, they can still call us. And that's an opportunity to engage them, because we would, when our resource and referral specialist would email us or put the encounter in and send it to us, they would say not enrolled. So that was an opportunity to say, oh, we noticed your practice isn't enrolled. We'd love to come out and do a training, and then we can build that relationship. And then it's much easier to do that. So that's also an opportunity to engage that practice. And then you can go out and do training and not only engage the person who called, but also the rest of their colleagues. It gets that word of mouth. And for us, if someone's enrolled, we provide it's a little easier for them to access resource and referral. Next slide. And then you heard about this from Christina too, like clear messaging about what services are needed. So for example, for face-to-face consultations, that we made it very clear we provide those and we can get people in within a couple of weeks. People love that. Even if they don't want to be a psychiatrist, which a lot of OBs don't, or they don't want to do any psychiatry, they love it that you can see the patients within a couple of weeks for us because that's a service we provide. And we made this very clear when we did any of our messaging. So, and some of that messaging we did through, we do webinars, like Christina said, we do the same thing. We do them once a month. Our toolkits has very clear how MCPAP can fit into their workflow through our website, our other resources, and then also obviously we're talking to them face to face. But it's really important for them to know you're here to help them and you're here to make their life easier, not harder, because I think that's often a misconception. Next slide, please. This is just an example. This is an example, like we had pads, we had cards, we had magnets, we had these lanyards and pens, and then we would go with the toolkit when we went to practices. I mean, nowadays this is harder to do unless you mail them to practices, but you could, for example, still mail this to people. Like if you do a training, you could mail these things to practices. Next slide. And as you can see, just to give you a sense of our enrollment over time, we've now served over, 12,000 patients. But you could see as our, now we've pretty much leveled out. We've enrolled about 77% of the practices in the state at this point, but as you can see that leveled out, but our certainly our service continued to go up and the two kind of are pretty proportional to each other. Next slide. And the other thing I would just say is that enrollment, training, and utilization are very synergistic. So if you enroll a practice and you train them, then like you heard about this from Christina, there's word of mouth, then they're going to tell their colleague and then they're going to use you and then you get more. Similar to what Christina said, we have not had to, we haven't done any marketing and our utilization continues to go up. And now it's really word of mouth because people will say, oh, I heard about you from my colleague or my friend recommended you or what have you. So our utilization continues to increase without us really doing any like direct marketing at this point. So these are all just synergistic with each other. And you do, I think, want that when people call, I tell people if they call, for example, tell your friend, we're happy to help, we're here, feel free to let your colleagues know, especially when they're frustrated. For example, with outpatient psychiatry, we often say, please tell them they can call us. We're happy to let because they don't know who can call. So it's important to let callers know who else can call. Next slide. I think that's finished. I think that's the last slide. Yep. So so that's a summary of MCPAP for moms and sort of what we've been doing over some of the things that were helpful. And I think one of the things that we can also talk about is how this is different during COVID, because a fair amount of the things we talked about are, were in person, but I'll add that now we do a lot of this virtually. So if we do have a request for training, we do it virtually. I think you don't get that in person, building relationships, but you can still do it. It's just a little bit harder. And I see we have a question in the chat. How long did it take before you saw the increase in utilization from the time you started the program? Do you want to go back to that slide, Melissa? Or Josephina, whoever's managing I can just bring it back. Yeah, so as you can see, in the first, in the beginning of our utilization, we were getting, not a ton of calls. So like in the beginning here in July, I remember our first month, we got about 40, I think we got 40 calls. So for the first few months, we were pretty much on average getting about 45, 40 calls a month. Then it went up to around, when you get to sort of 2015, we were getting 50 to 100. And then when you get to 17, we started getting 100 to 200. And now we're getting pretty typically between 300 and 400. And actually last month we were over 400. So it's, I'd say that it increased steadily over time. So in the beginning, and it just kept going up, but it continues to. And I do also want to add that our utilization, these are not all telephone consults because we do provide a fair amount of resource and referral. And for enrolled practices, they can get resource and referral without a telephone consultation. So not all of this utilization is telephone consultations. So just to be clear about that. So we're not getting we're not doing 400 a month consults with OB providers. We're doing a lot of resource and referral, and then we're doing also consultation with OB providers, just to clarify that. You can put the slide down, thanks. Does that answer your question, Nagala? Okay, great. So other questions for Christina, comments? I'm especially curious to hear what has been successful for other programs, what challenges people have, and what kind of things people experience that they want to hear from others about, and particularly how we can adapt some of these methods during, we want to say we're post-COVID, but we're not post-COVID. We're just not. So that's the reality for a little while.
Nancy, I have a question.
Yeah.
I'm thinking about, and this is kind of related to a conversation Mary Kimmel and I have been having, but I think you guys, and I'm not sure if Wisconsin, if you guys have, I know you do in Massachusetts, have like a hub model. Mm-hmm. And I'm wondering if you guys could kind of talk about like how that has impacted, in terms of the outreach component, but I think also just in terms of the service component. We've had a lot of questions about this as we've thought about regional hubs, and like how centralized does our program remain? How do we explain that to people? Is it confusing to have like a care coordinator who handles the East? And anyway, I'm just interested to kind of hear more about that from an outreach perspective.
Yeah, that's a great question. So we do have a hub model, and because we have, so our, Massachusetts has 72,000 births. And so we have a hub in the central part of the state, where I am in UMass, in the central part of the state. We have a hub in the western part of the state. We have a psychiatrist there. We don't have a resource and referral specialist there, but we have a psychiatrist there. We have a psychiatrist in the middle part of the state, central Mass. Then we have psychiatrists in the eastern part of the state in Boston. And so I don't actually think it's confusing at all. We have one number that everybody calls. And for when people are calling, they don't know what hub they're reaching. If there were separate numbers, I think that'd be super confusing. But it's 1-855 line. And we have this 8x8 system that is, I don't know if I'll ever fully understand it, but Beth McGinn could tell you all about it. But it's like this 8x8 and it rings and we somehow transfer the calls based on, whose shift it is, basically. So if it's, person in Boston shift, it goes to them. If it's coming to Central Mass, it goes to them. And we're somehow doing that now virtually as well, with everyone being home. Most people are still working from home. So so I don't think from a consumer's perspective or from the provider's perspective calling, we've never heard feedback that's confusing, because it's still one phone number. So really, it's all for us internally. So how we manage that internally is that if in the beginning, we were doing all these in person. So like if there was a consult that needed to be done for a patient in Western Massachusetts, the psychiatrist in West Mass would do it. Now we can cross cover each other, and that's actually less relevant. But, I was actually just talking to the chair out there this morning, and we were saying how it's so important to still have a psychiatrist out there, partly because they each have their own women's mental health clinics, and having someone at that center who is, kind of greasing the wheels and helping with the triage to their clinic if they need to is super helpful. So, at Massachusetts, so for example, at UMass, Rouge and I are here. Rouge directs our clinic. She's one of our psychiatrists. And, we can sort of work with her to like, we take a call and then we think, can we take him in our women's mental health clinic and so forth. So we kind of figure that out per hub too. And we have not found that to be particularly challenging. Does it answer all your questions, Karen?
Yeah, that's helpful. I think we're thinking about, and this is like way in the weeds, but yeah, we're thinking about like the phone number, and we're like, well, we have to keep one phone number, but yeah, then even thinking about like, as you're creating these regional partnerships and how you, I think for our program, like a real strength has been, I think we've just, we're a small team. So we just have a lot of like face and name recognition. And so as we've been thinking about like, what would it look like to build out, to bring in regional partnerships, and how that would change our outreach. Yeah, and
I think the way it can change outreach is Christina had mentioned too, that you want to use the clinic that like within your academic medical center, like that's the lowest hanging fruit, right? You go to your buddy in the OB, like in your same institution, say, hey, you can call us. And like, if you have 3 hubs, you have 3 academic medical centers, or perhaps not, because I know a lot of states don't necessarily have academic medical centers as I'm saying this. So like, but whatever within your region where you have relationships, and it just increases the amount of low hanging branches that you have, I would say. I think that's the other benefit. So I think we got a bunch more questions. So, okay. What counts as utilization, cap calls, behavioral health calls, embedded visits, resource provision, outreaches? I think I would say all of that. We don't count outreach as utilization. We count that, we count that as training. But if there's, if someone calls our program and we provide a telephone consultation, that's utilization. If we do a face-to-face consultation, and if we provide resource and referrals. But when it gets counts as utilization is if they call us. If someone has an embedded visit at UMass, but they haven't called MCPAP for moms, that's not it. But we wouldn't count that. But if they call us and then we end up referring to Aruj and Aruj sees them, then that would be an encounter. But we don't count there. So that's how it works. And it depends if they're doing it within our program. Do you have anything to add to that, Christina, as far as how you count it? Is that consistent?
So we don't have the face-to-face component. So we count, so basically anytime that somebody reaches out to us via our telephone number or our email. The difficulty that we had, especially early on, is because I was a one-woman show for so many years and people just called. We also had the caveat that if people reached out to me directly and didn't go through our 1-800 number or email, we would tell them about Periscope and include that as a Periscope consult because of how it was doing it. So we made it very clear to people who, so like my OBs that I worked side by side with, I told them, here, we've got this great program, use the 1-800 number. But if you've got a question, call me however you wanted to, right? Because these guys have been calling me, just picking up the phone, my cell phone, or texting me for years. I also didn't want to put extra burden on them by having to utilize Periscope. Now, 4 years later, all of them recognize I will get back to you a hell of a lot faster if you call my 1-800 number versus calling my cell phone. So they're all now trained to utilize Periscope. But early on, we actually had this direct connect to, the direct connect radio button as well. So
I have a friend of mine, for example, that would text me and I'd be like, call MCPAP, because we have 5 psychiatrists. So we really had to do that early, but it's a little hard when they're like your buddy and they're like, what do I do with this patient? And you're like, you gotta call. Like I just, sometimes you would call in and then we still have a conversation. I'm like, we should have dinner. But like, I think it's, but I think you can, that ends up happening as well. So I see, do you provide resource and referral service without a phone call at all? No, we do not. I know it. I don't think you do either, right, Christina? We don't provide any resource and referral without a phone call. It's all, and they cannot do it through electronically. They have to call for resource and referral. If a practice is enrolled, we will contact the provider and send a list without a phone consult. For us to contact the patient, we always have to have a phone consultation. Okay, NC Matters allows R&R without a phone call, but that's Karen answering. Thank you, Karen, that's helpful. Okay, Eva Ray has a question here. Okay. Oh, you're saying what you do. So it looks like Rhode Island P for Moms does the same. They now initial requests for in-basket message. However, psychiatrists do not complete the actual consultation. That must be done by phone. Okay, then we got a question from Sheila. Who owns? So obviously, like just based on Karen and Eva's comments, there's lots of ways to do this. So Sheila asks, who owns MCPAP? So that's a good question. So MCPAP is a statewide program and it's funded by the state. It's a line item in the state budget. It's officially funded by by Massachusetts Department of Mental Health. They contract with Beacon Health Options, which is basically a healthcare, an insurer who does our public health insurance. They do Mass Health, they do a Massachusetts Behavioral Health Partnership, and they then contract with each of our hubs. So line them in the state budget, funded through Mass DMH, they contract with Beacon, and then every year we have a contract with Beacon to it covers my time to direct the program and do clinical work for the program, and same at Brigham and at Bay State, which are other hubs. So, and for the branding, it's all MCPAP for Moms. We don't do anything with everyone, just all of our branding is based on it being the statewide MCPAP for Moms. It's not a UMass program. It's not a Brigham program. It's MCPAP for Moms. And so for example, and that's how we basically advertising, and they call the 855 line. So they don't know if they're talking to someone from UMass or Brigham or what have you, unless it comes up. And then a question, how are legal issues handled between universities and mitigation of med legal? We haven't had that come up actually. I'd say that when we first developed it, we're just very clear that we're not providing when we're providing consultation, then it's educational, and then we wouldn't tell a patient, if an OB calls, I don't say you should give them lamotrigine. I say, sounds like the patient you're describing, it sounds like X, Y, and Z. And those kind of cases, often the approach might be to do X, Y. I don't tell them oh, this patient has this, you should do this, unless I see them. So it's more educational and it's less directive, and that sort of mitigates the medical legal. And our website is We just make sure website language is consistent, but we really haven't had any med legal challenges or issues
So
between.
so our issue is we're mostly a University of Michigan program, but we're thinking of moving in that direction, is the same as MCPAP Vermont, it's kind of a statewide, but bringing in Michigan State. And we anticipated we would need to go to Michigan medicine attorneys and say, we're going to bring in Michigan State psychiatrists to do our consults. So the legal team didn't flip out when that happened.
No, we didn't even ask him, honestly. We just did it.
Okay.
Like, it's like, we're just collaborating on a clinical service. Like, even when MCPAP for Kids was developed, I have never heard, honestly, of like needing to go through attorneys.
Nancy?
Like, oh, go, John, please add.
Just to point out, in terms of the medical legal, the key to these is that you're not creating a doctor-patient relationship.
Right.
So as long as you're not talking to the patient, then and you're consulting to the provider, docs have been doing so curbside consults forever, and there is a good case law that does not have medical legal risk. As soon as we see a person face to face, then they get registered in the clinical system where they're being seen. And that has to follow all the rules of the institution, because that becomes a clinical, becomes a full medical legal visit.
Yeah.
But if you're just doing the phone consult, the case law, and there's some very good papers, including one analyzing a whole bunch of the kids programs that show that there have been no cases, as far as we know, where someone has been sued.
Well, it may also be that if you get all the branding and the marketing and the slides and the everything under in our case, Michigan Department of Health and Human Services, and out of Michigan Medicine, it'll be better.
I guarantee you, when we started this, it was before MCPAP Vermont, so we started using the same institutions. We talked to a lot of lawyers to convince them. These academic lawyers were very uneasy about this, but we got there, and they're now pretty accepting.
Thank you for adding that. So in MCPAP Vermont, we benefited from that, all that work that had already been done. That's why I'm like, we didn't talk to anybody because MCPAP for Kids had already done it. So thank you for adding that, John. That was super helpful. John founded the original MCPAP program, which then, was the, foundation for, a model for MCPAP for moms. So I see I know we're running out of time. We have a couple of questions here. Curious about outreach to social workers. Can MCPAP get referrals initiated by social worker agency? For us, I think different programs do this differently. Currently in Massachusetts, it has to come from an OB, or it has to come from a medical provider. That our model is that we're building the medical home. And so right now they come from medical providers. I do think that differs across different states. And I think the last question for Maria, because we're almost out of time here. What are the main issues that you heard in your state deterred from using your service, if there are any, e.g. burden initiating consult, too much info to share? I would say the biggest thing that we found, the irritated the OBs when they felt like we were trying to make them into a psychiatrist. Or they said like, it's too much. They do sometimes say it's too much work. They'd love to email us, but I think email just doesn't really work for this model. That's been ours. I mean, I think there are models where you can do that, but we don't do email. But I think the main thing we heard was that they called and that they want it to be very practical and quick. And they can't, OBs are busy surgeons. Like there's only so much they can tolerate. They don't want to like talk about their patients for hours like some of us psychiatrists like to do. And like, they just want to be like cut to the chase. And I think when our psychiatrists were like, oh, you should like start this. We just needed to meet them where they're at and like know that they had their back without like making them and giving them a choice. So even if we can't, saying we get it, I think that was the main thing. And they would always call and say, we want you to take our patient in the beginning. So I think that was the main burden, is they felt like they didn't have a choice and they were being forced to do something they didn't want to do. And I think you can get over that by just giving them a choice and saying, it's hard. It's up to you. You can either treat them or we can refer them, and it'll take a really long time, or we can see them for one-time consult and then you can treat them after that. But we can do that in a week. What do you want to do? And they're always like, okay, fine. If you see them and you do it in a week, that's great. I'll treat after that. So that's been our approach.
And we don't have that option. And so my biggest piece that we actually heard was just that they were so afraid of how much time it was going to take. And so by having that schematic infographic of literally, now that we've been doing this for a few years, to demonstrate the average times for each of them and what that could actually look like has been incredibly helpful. And unlike MCPAP, we allow anybody to contact us. So maybe it is the social worker who puts in the first phone call. Maybe it is the nurse that then can give us a whole bunch of information, and then we can just talk directly to the provider. We'll talk to anybody and tailor the consult directly to the calling provider. So it obviously would be a different consult to a social worker, lactation consultant, than it would be to an OB. But we've done, that's how we've kind of gotten around that. Like once they use it and see how quick and easy it can still fit into their day, that's been the biggest concern we've had from providers, just getting over that first hump. So
I would agree. I mean, it's interesting. Our providers don't seem to really, often they're just like, call back anytime that day. They're not that focused on how quickly we call back, but it's different. Like, and this is one size fits none, right? All of our access programs across the country, we all just tailor them differently. And like what works in Wisconsin, it's different in Massachusetts and Michigan and so forth. So it's just, our providers aren't that focused on that, but they're focused on different, it's interesting. But thank you, Christina. That's really helpful. So I know it's 5, so be respectful of everybody's time. Thank you. I'm glad everyone was asking great questions and seems engaged. Please fill out the survey. And I think we could probably keep talking about this. We probably have another one of these relatively soon. Thanks, everybody. Enjoy your evening.